Hi, everyone. I'm Dr. Laurie McCauley, and I am so excited to have you here today for our webinar, CCL Disease Decoded, the latest in diagnostic and early intervention. This is a topic that Dr. Laura Romano and I are incredibly passionate about, and we've been working hard to bring you the latest insights and practical strategies that can truly transform your approach to cranial cruciate ligament disease. Imagine being able to stop cranial cruciate disease in its tracks before it causes pain, before arthritis sets in, and before a rupture changes a dog's life forever. That's the power of what we're going to explore today. CCL disease is one of the most common and devastating orthopedic issues in dogs. But what if we, as veterinarians, could intervene earlier, identify the subtle signs, and give pet parents the tools to prevent its progression? This isn't just about treating ruptures. It's about transforming patients' outcomes entirely. We're going to dive into the demographics, who's at risk, what signs we need to look for, and what changes we can make. By the end of this, you'll have actionable knowledge that every veterinarian should be aware of. Here's something I really want to emphasize. Cranial cruciate rupture is almost never an acute issue. It's rarely caused by trauma. Instead, it's a result of a long degenerative process within the joint. This isn't just a simple tear. It's a progressive condition driven by structural changes in the joint over time. The good news is we can identify the early signs of the disease and have the opportunity to intervene. By slowing or even halting the progression, we can dramatically reduce the chances of rupture, surgery, chronic pain, and secondary arthritis. And here's a little incentive to stick around. If you stay until the end, we have a special surprise for you. You're definitely going to want to hear about it. So don't go anywhere. Let's talk numbers for a moment, because they really put the scope of this issue into perspective. Cranial cruciate rupture is now the most common orthopedic procedure performed in dogs today. For many surgeons, it makes up to 50 to 80% of their orthopedic caseload. And it doesn't stop there. Up to 50% of dogs who tear one cruciate ligament will tear the other within 2 years. It's not just an isolated problem. It's a cascade. In the general dog population, 0.6% of dogs will tear their cruciate and undergo surgery. For certain breeds like Labrador retrievers, that number jumps to 4 to 6%. And remember, Labradors are the most common breed we see in practice. And they don't even account for the cases that go undiagnosed or untreated. This is why understanding and addressing CCL disease is so important. It's not just about the individual case. It's about shifting the narrative for our patients and their families. Why is understanding cranial cruciate disease so critical? Because every dog with cruciate disease, whether they undergo surgery or not, will inevitably develop arthritis. That arthritis stems from inflammation that not only causes pain after the rupture, but can also lead to discomfort long before the ligament tears. While we have anti-inflammatory medications to manage the pain, wouldn't it be better if we could intervene earlier? Imagine slowing down the progression or even halting the cycle of inflammation, rupture, arthritis. I want to tell you about one of my patients, Kaiju. Kaiju is a beautiful border collie who came to me at just 2 years of age. Her mom had big dreams of seeing her on the world team for agility. But during her exam, I had to tell her mom, Kaiju has a fusion in both knees, crepitus bilaterally, and fibrous tissue at both patellas. Kaiju had straight stifles, which put her at even greater risk for tearing her cruciate. Now, I'll tell you more about what happened with Kaiju in a bit, but her story is a reminder of why early diagnosis and intervention is so crucial. Now, I'm thrilled to introduce my amazing colleague and friend, Dr. Laura Romano. She is an extraordinary veterinarian with over 30 years of experience and an impressive list of credentials. Dr. Romano is certified in chiropractic therapy, acupuncture, rehabilitation, and advanced neurological veterinary spinal manipulative therapy. And she's one of less than 120 vets board certified in canine sports medicine and rehab in the world. Her expertise is unparalleled, and I am so honored to have her here to share her knowledge with all of us today. For those of you who may not know me, I'll give you a quick introduction. I'm also a vet who's certified in acupuncture and chiropractic therapy, as well as board certified in canine sports medicine and rehabilitation. I've done a lot of really cool things, but what I want you to know is that teaching is my passion. And now I'm going to hand things over to Dr. Laura Romano to dive into some truly eye-opening information. Don't forget to stick around until the end. We've got some exciting surprises that you won't want to miss.
Hi, I've titled this section, Let's Think About Cruciate Disease. I didn't mean that to be a silly title. I want to think about this disease and all the bits about it. I'm Laurie Romano, a rehabilitation specialist in Canada, and I've been boarded by the American College of Veterinary Sports Medicine and Rehabilitation since 2016. But I started loving rehabilitation way back in the 1990s, and Laurie McCauley, who has been instrumental in bringing this all together, was an influential mentor to me way back then, as she's always been at the forefront of mobility in dogs. Is this the right time to think about cruciate disease? This is the classic way we think about cruciate disease. It is present when the cruciate ligament is torn. But is this the most beneficial way to think about things? Is this the best time to intervene? Spoiler alert, my answer is no. Let's start at the beginning. I want to zoom in and look at the details. Let's look at the anatomy, at the cellular level. Can we make a change there? Understand the genetics risk we are facing? But that is so we can zoom out and see the whole picture. Can knowing the details help change the course of the disease? In rehabilitation, sometimes we have a paucity of information and must rely on fundamental knowledge to enact treatments and plans. I want to take you on a journey of that knowledge so that you are resilient in the face of complications and resourceful to help prevent or defer disease. Today, I want to give you a taste of that journey. Let's change our minds about when to consider cruciate disease. Most people don't talk about cruciate disease at this point when the dogs are puppies. But could we guide them better with an index of suspicion? Let's think about the risk factors and try intervening earlier rather than later. To do that, we need to know some, arguably boring, stats and increase our index of suspicion. Firstly, can we make some guesses related to age? That's a straightforward data point to get. There are also some significant patterns related to age and cruciate disease. Boxers tend to have cruciate disease early and more severe arthritis, and their heritability index is higher than average. So, our degree of suspicion goes up when we see a boxer, but also our willingness to be aggressive with prevention and arthritis management if needed. Can we make a guess related to breed? Well, we just mentioned boxers have a different pattern of cruciate disease. Are there other breeds that we should have more suspicion about? You knew the answer before I told you. Of course, the answer is yes. The general population has an overall prevalence of 0.6%. That may seem low from our clinical impression. However, many popular breeds have a higher prevalence. In labs, the prevalence can be between 4 and 6%.
Besides breed, let's look at posture. The first thing we want to look at is angulation. We know that in most cases, dogs that are straight-legged in the rear are more likely to tear a cruciate. It just is, right? Lots of research. So how do I know if my dog's straight-legged? Well, we look at the angulation. How do I know what the angulation is? I'm going to show you. In this Akita, he's pretty straight-legged. If we have him in a stacked position, meaning his metatarsals are straight up and down, and I measure the distance from the line of his metatarsals up to his greater trochanter, the top of his hip, tiny little distance. He's pretty straight. In comparison, if we look at this lab who's angulated beautifully, if we take the line of his metatarsals and go straight up, it's a long distance to his metatarsal, or to his greater trochanter, or the top of his hip. He has beautiful angulation. He's much less likely to tear his cruciate.
If we find a dog with cruciate disease, what are the chances of the other leg being affected? What I found remarkable as I researched this program was the prevalence of cruciate disease, which had already started in the other stifle if we looked for it. If it is stable, how can we say that there is start of disease? And if the disease is present, what can we do about it? This is where things get fun. Understanding the course of the disease and jumping in so much earlier. As for bilateral disease, there is also breed differences. Rottweilers have the highest chance of that, and golden retrievers are much luckier in that regard. We can suspect things as soon as we enter the exam room. Knowledge is power. It is like feeling like a superhero with the power to spot disease before it's even symptomatic.
My turn. I want to share with you one of the first things I see looking for cruciate disease. So let's start with effusion. Effusion is fluid inside the joint. It's inflammation. So the cells on the inside of the joint capsule release chemicals that say, hey, there's something going on here. Let's get some chemicals to tear things up. And here's our effusion, right? This is not supposed to be all pouched out. Here's my femur, here's my patella, here's my tibia, here's my fibula, my cruciate ligament sitting in here. That fluid sits and wraps around those cruciate ligaments, cranial and caudal cruciate ligaments. And what's going to happen is as they're degrading stuff, bing, 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 little fibrils are going to pop. And if enough fibrils pop, we're going to have a partial ACL tear or CCL tear. And we can also have a poof where the whole thing just blows. We don't want that to happen. So we want to find these problems and fix them before they become big problems. So how do we know if there's effusion? Any dog, if you bend their knee, there's going to be two bumps. The top one is going to be the patella. The bottom one is going to be the tibial crest. And between those is the patella tendon or ligament, depending upon what you want to call it. And if you put your fingers on either side of that, it should be nice and concave. There shouldn't be any fluid that you can feel, any fluid motion. If there's fluid motion or if it's pooching out, that's effusion. And that means there's a lot of inflammation in there. We want to catch it way before that happens. I can't wait to share this with you also. Now on to something that hopefully will change your life. Something that you'll go, oh my gosh, that makes so much sense. And I can check every dog that comes in and see if they're predisposed to having a cruciate injury. And if so, fix it before it becomes really bad. So we don't get to any of those changes in effusion. The first thing that happens is we have thinning of the joint fluid. And when the joint fluid thins, that patella is going to rub on the femur. So we're looking for crepitus, but not like that that you're used to feeling. This is very sensitive, very small, and you have to do it right. Most of the time when we think about crepitus, it's between the two main bones. But we have a meniscus here, right? We have something that's going to protect us from that, which is good. But our sensitive test is between our patella and our femur. So what are we going to do? We're going to put our hand on the patella and put pressure down. Then we're going to flex and extend by moving the tibia and see if that patella catches. It can catch at the top or in the middle. And you'll just feel that little, and you know that that joint fluid is thinned. And if we can do something, we can make it go away. So take a quick look at the video. There you go. I have my palm pushing into it, and then we do flexion and extension. Let's see if we can do that again. There we go. We're going to flex and extend and see if we have any grinding at all felt in our palm.
Then we start zooming in a bit. Why is anatomy essential? Why is a drawer more likely to be found at 135 degrees? Why is a cruciate ligament hypoechoic on ultrasound? Those answers are found in the anatomy of these structures. As we zoom out, we can look at bone conformation, which can affect surgical outcomes, even if it's something we can't change with rehabilitation. We should know this information to create individualized rehab plans. The meniscus is a critical passive stabilizer, How much thought have we given to the meniscus? Is it limited to releasing it during surgery or removing part of it if it's torn? The meniscus is prone to injury. The reason for the increased risk is rooted in the anatomy of the attachments. See how important anatomy is? What are the outcomes when a release or resection is done? These images show a normal pressure map. In the A figure, notice how the pressure are distributed throughout the bone structure. B is showing a meniscal release. There is a dramatic concentration of pressure, which is detrimental to the cartilage and bone structures. And C is showing a hemimeniscectomy, where the pressures are even more concentrated. The release, though, is almost as harmful to the underlying structure as the meniscectomy. Knowing this, how does this change your approach? Would you be more likely to inject hyaluronic acid or HA into these joints, knowing what is happening on a cellular level? Meniscal releases are the answer to protect the joint from future meniscal tears, right? It's sort of a yes and no answer. The answer is yes in some studies and in others, no. The procedure itself is not entirely benign. However, understanding the importance of the meniscus will help create better long-term outcomes for these dogs. In rehabilitation, we manage these guys with normal, released, or hemimeniscectomized menisci for 5, 10, or more years after surgery. We need to know what obstacles we're facing. We touched on the meniscus. However, the joint is an organ with many components. We need to understand the anatomy of that organ and how it is affected by or affects cruciate disease.
Do you like what you hear? At the end of this, we're going to give you a way to learn even more about cranial cruciate disease.
We move on to look at motion. What can we see? What are our limitations? It is great that we can visualize motion and learn from it, but it's just one component. It is just part of a complete examination. Understanding limitations in gait analysis is important to 1, rely on other diagnostics, and 2, stop beating ourselves up. I harp on this a little bit because if we don't see a lameness, it doesn't mean cruciate disease is not present. I encounter many students of rehabilitation who are frustrated that they don't possess the clairvoyant knowledge of what the dog trotting in front of us is trying to tell us. Let's have confidence in the knowledge that we have many tools in our bag, and gait analysis is just one of them. That being said, get these guys moving and put the information that you can glean into your plan. Even without seeing all things during gait analysis, there are pieces of the puzzle that we should know. Muscles are strong enough to reduce a tibial thrust during the swing phase. That is the time when the foot is off the ground. But those muscles are not strong enough to counteract the ground forces, and thus the tibial translates forward during the stance phase or when the paw is touching the ground. The stifle is very complex. There is flexion and extension, which is the easiest to see. But there's also rotation and translation. Many things are happening at once. No wonder our eyes can't pick it all up. However, we can see some characteristics present in cruciate disease. We see flexion and extension as the most straightforward motion to visualize. Dogs with cruciate disease will tend to walk with increased flexion. Some changes in the rotation have been documented, but they are so small, just a few degrees, so we will not see them visually. Can we control these forces with bracing? Of course, the answer is yes and no. The critical consideration, though, is whether we can make a difference clinically. And that answer is a definite sometimes. Understanding the complications, such as pressure sores, are not uncommon. These are incredibly tiresome in dogs with thin coats, such as Dobermans. That is why choosing the right candidate and circumstances is essential to success. We jump ahead a little bit. How did we find cruciate disease? Can radiographs help? The answer is not as straightforward as we would want. The cruciate ligament is not directly imaged on radiographs. So we need to look at things that we can see that may indicate a problem. Do we need a tibial thrust to diagnose cruciate disease? The simple answer is no. But really, there is so much to unpack there. Are there radiographs that can predict cruciate disease? If you're asking me to take a clinically normal 1-year-old dog and predict cruciate disease 5 years from now, that's a stretch. But radiographing the contralateral stifle is an absolute must. And why am I so excited about this image? This image may be what you see when looking at the contralateral side. It is essential to have this information.
I want to show you what I look for when I'm looking at x-rays to help you catch things quicker. So this is a normal x-ray, a beautiful x-ray of a healthy dog. Things that we look at. Here's my patella, my kneecap, and it's nice and smooth right here. My fibelle, behind the knee, that's where the gastroc attaches. It's nice and smooth. I have a fat pad, so here's my patella tendon or ligament, whichever you want to call it. And then behind that, that black area, that's my fat pad, right? Because fat has less density, so it's more black. My top of my tibia is nice and smooth. Here's a really bad one, okay? Here's my normal one. Let's look at all the different things. Here, I have changes to my patella. Can you see calcification coming down that patella tendon or ligament? I have, instead of a nice big fat pad, I have fluid that's pushing it out. Now my fat pad is smashed right in here. That's all fluid. I have fluid back here pushing out all this fluid. Oh my gosh. And my little cruciate ligaments are sitting in here trying to do their job so much and struggling because of all the inflammation and the degradative chemicals around them. My fibelle, they're not smooth anymore. Top of my tibia, right? It's not nice and smooth. It's thickened, increased pressure. We may even see some little bumpies. That can be calcification in the meniscus because that's where he sits. Now, we may not only see really healthy and really bad. So let's look at some in between. Here's some mild changes. My patella's not bad. I have my fat pad. Oh, but look, I have a little bit of fluid sticking out right here, right? That's my beginning of a fusion. As we come here to more moderate, now I have more fluid here. My fat pad is being pushed. Here's my fat pad. Here's my ligament. Tiny little changes on my patella. Little changes on my fibelle. A little bit of thickening here. And then here's my severe. My little, if you're old enough to remember, we always call it Jimmy Durante's nose, right? It's that calcification coming off the patella. My fat pad is just about impossible to see. It's a tiny little black line between my tendon and my fluid, right? I have bumps here on my top of my tibia, and my fibelle is not very happy.
Now we are going to touch on one of my favorite things, which is patellar palpation. More specifically, feeling for the joint effusion that pushes up on either side of the patellar tendon. It is one of the earliest signs related to cruciate disease. You can feel it by placing your fingers on either side of the patellar tendon. The skill starts with you feeling every dog that visits your exam room to feel many normal joints. It takes about 10 seconds to do. A typical cruciate disease exam is based on a drawer sign. But did you know that the sensitivity of this clinical sign is only 60 to 69%? Sensitivity means the testability to correctly identify dogs with a disease or true positives. A highly sensitive test has few false negatives and misses fewer disease cases. 60% is not a highly sensitive test. However, the sensitivity does go up with general anesthetic. But don't rule out cruciate disease in the exam room if the drawer is negative. So of course we use a cranial drawer sign, but it's just one tool. Okay? Thankfully, the specificity can be 100%. The specificity is a test's ability to correctly identify dogs without disease or true negatives. A highly specific test has few false positives. So answer these questions. If there is a cranial drawer, do I have cruciate disease? And alternatively, if there is no cranial drawer, Do I have cruciate disease? There is an incomplete cruciate ligament if there is a cranial drawer motion. A drawer is an excellent test in that regard. You can confirm the disease with a drawer test, but cannot rule it out. But in this course, I want to add to your knowledge about two things. Firstly, a negative drawer does not rule out cruciate disease. And secondly, a positive drawer, if it happens in the middle of the spectrum of cruciate disease, not at the beginning and not at the end. The other motion test we have is a tibial thrust. A tibial thrust test mimics the forces of the ground. Remember I said that muscles are not strong enough to overcome the ground forces. Since I know the muscles have a challenging time overcoming this move, I use it more in awake dogs. Clinically, I find it more comfortable for the dog, but that's just an opinion. So a tibial thrust is not present with a TPLO, since a TPLO neutralizes those ground forces, but a cranial drawer is still present with a TPLO. Let's backtrack to that meniscus. I wonder why we're not always talking about patellar palpation. In this chart, the sensitivity, specificity, and positive and negative predictive values of different clinical tests are compared. Both radiographs and patellar palpation are clear winners, and both are looking for joint effusion and not abnormal motion. The idea of abnormal motion as the start of cruciate disease, I hope, is fading. Some things are also simple and fast, and you can do it the second they walk into the exam room. We can also teach clients to look for these signs. Puppy sitting or sitting to one side is often a result of increased stifle joint effusion. In a highly flexed position, the pressure increases in the stifle and creates discomfort. So they sit to one side with the leg extended to relieve that pressure. Weight shifting while standing is also easy to see. Dogs typically will stand as a square, but when one leg is sore, the stance turns into a tripod. They will place their normal hind limb more towards the midline. We can also see the weight shift in the toes. The decrease of weight bearing is seen with the toes less flattened, and the metatarsal pad is seen more easily. Measuring muscle mass is something that we can investigate. A quantitative way to do this is by picking the same landmarks on each leg. Usually these landmarks are 50 or 70% the length of the femur. Using a gulick ensures the same tension is placed on the measuring tape. However, a clinical investigation can quickly be done using a qualitative approach. Encircling your hands around each leg at the same height and comparing the two distances will enhance your clinical impression of pathology. Dogs will lose muscle mass on a leg that they are chronically underusing, so it can also indicate chronicity. So, we have diagnosed cruciate disease. I'm hoping you are starting to remove the idea from your mind that cruciate disease starts with instability and ends with surgery. Surgery is an essential tool in the middle of the disease, but it is in the middle, not the beginning or the end. The most common surgeries are tibial plateau leveling osteotomies, or TPLO, tibial tuberosity advancement, or TTA, and lateral fibellar sutures. For most rehabilitation practitioners, surgery is not our focus. We should focus on the fact that arthritis will progress no matter the surgical treatment. Even though surgery is not our focus, we must understand it. Since we will seek to intervene in cruciate disease before there is instability, we need to know all the options we have and what evidence there is for each use. This includes surgical options for partial cruciate tears. So, let's say we've had surgery. Now, what exercises are we going to prescribe? Understanding why we are doing that and how to do it is essential. The prescription of rest or no exercise is pervasive in the veterinary community, but all situations are different. Understanding some fundamentals of what exercise can do helps with our decision-making process. Knowing the risks and the effects, how it modifies pain, and some kinematics helps us make a treatment plan. I have not yet appreciated a concise, repeatable, published approach to post-cruciate surgery. There are many papers that describe the program they use in their research, but the treatment plans are not standardized across the literature. So we have to use our knowledge and the assessment of each dog to make each plan. One of the key concepts that we need to use exercise is to train the dog's body for the activities the dog wants to do. If the muscles have the strength, body awareness, and coordination to do what the dog wants, the risk of injury diminishes. Pain control is a significant effect of exercise as well. Exercise is an inexpensive and effective pain control for chronic arthritis, which should be emphasized. Should we prescribe rest? Studies suggest that inactivity may predispose tendons and ligaments to altered and detrimental homeostasis. So rest is not benign. Sometimes it's needed though. Use rest thoughtfully. How much exercise should we prescribe? I base my recommendations on the concept of an acute-chronic ratio used in human training. So if we do the same exercise we did before, the risk of injury is at its lowest. Doing exactly what you did before gives a score of 1, but both a decrease and an increase in activity can increase the risk of injury. Most of the time, we are interested in increasing activity. So to simplify the math, I advise a 10% weekly increase. Using time or distance helps quantify this. Once we add higher velocities, higher impact, or rotational forces, we encounter gaps in the available data to allow easy quantification. Even so, we can still adhere to the slow addition of exercise. This gives the body time to respond physiologically and keeps injuries low. Areas targeted with cruciate disease tend to be strength, proprioception, and core. Dogs are such natural endurance creatures that I generally don't specifically focus on endurance. Of course, there are some exceptions, but most people are not training their dogs for a 1,000-kilometer sled dog race. Exercise works to both prevent the onset of pain and resolve pain after injury. But we need to educate owners regarding this. It is hard for us to imagine all the activities dogs do in their daily lives. But if we get owners on board to train their dogs for the activities they do, there is no reason these guys can't have a fun and comfortable life. I've really enjoyed putting together this course. It goes a little fast and furious, but it is a fun ride. Join me on this journey to understand more about one of the most common concerns for our patients. Thanks.
Here's our first exciting surprise. Optimum Pet Vitality has created a comprehensive course tailored just for you. Cranial Cruciate Disease 101, Diagnosis, Management, and Care. This 3-hour course is packed with 8 modules, delivering a dive into a critical topic of cranial cruciate ligament care. Dr. Romano has meticulously reviewed over 300 research articles, distilling the most relevant findings into an accessible and practical learning experience. And here's the best part, you have 6 months to explore this material. Whether you prefer to pace yourself or tackle it all at once, the flexibility is yours. Every video in this course is under 30 minutes, making it simple to fit learning into your packed schedule. The content is engaging, easy to follow, and designed with your needs in mind. The course is race approved for 3 hours. We provide detailed proceedings to accompany each module. The goal? Empowering you to help your patients while protecting their knees and their future. Who is this course for? Honestly, every general practitioner can benefit from this knowledge. Cranial Cruciate Disease 101 is also a perfect fit for rehab veterinarians, technicians, and physical therapists who are passionate about preventing or slowing down CCL disease progression. It's designed to provide real, actionable knowledge for professionals at every level. So what will you learn in this foundational course? Let's break it down for you. Cranial cruciate disease, a historical perspective with modern insights. Meniscal manners, understanding gait, tools and limitations, and there are some. Bracing versus surgery, super important. Surgical solutions, TPLO, TTA, and beyond. Healing from within, the power of intra-articular injections. Accurate diagnosis, cruciate disease exam techniques. I promise there'll be some new information for you. And exercise as medicine. Once you've completed Cranial Cruciate Disease 101, you'll be ready to take your expertise to the next level with Mastering Cruciate Disease in Dogs, surgical and non-surgical approaches. This course, exclusively available after taking CCL 101, continues the journey into deeper, more specialized topics. Dr. Laura Romano brings her vast experience to guide you through the next steps. So what's included in the advanced course? Here's a sneak peek. We have imaging insights, radiographs for cruciate disease, advanced imaging, CT, ultrasound, MRI, and more, synovitis and inflammation, early signs of cruciate disease, contributing factors, anatomy, blood flow, and neurology. Believe it or not, it's all connected. Pivot shift phenomenon, understanding post-surgery instability. It happens, and we need to know what to do about it. Stem cells and PRP, unlocking regenerative therapies. You definitely want to know about that. Rehabilitation tools, enhancing recovery from cruciate disease, and comprehensive recovery, designing effective rehabilitation protocols, and that ties it all together. Thank you for spending your valuable time with us today. To show our appreciation, we're offering an exclusive 20% discount on our course, Cranial Cruciate Disease 101, Diagnostics, Management, and Care. Normally priced at $299, you can access this course for just $239. But the special offer is only available to those who have watched this presentation. In this course, you'll gain practical tools to identify CCL disease earlier, reducing pain, arthritis, and improving patient outcomes. And to make this decision stress-free, we're including a 7-day money-back guarantee. Explore the content, absorb the insights, and if you decide it's not a right fit, no problem. This is your opportunity to invest in your growth. Ready to take a deeper dive into CCL disease management? We've created a special bundle for veterinary professionals who want to elevate their expertise. For just $398, you can enroll in both Cranial Cruciate Disease 101 and our advanced course, Mastering Cruciate Disease in Dogs. That's a savings of $100. Remember, Mastering Cruciate Disease in Dogs is only available for people enrolled in Cranial Cruciate Disease 101. These courses condense insights from over 300 research articles into actionable strategies that you can apply in your practice immediately. Whether you're looking to refine your diagnostic skills, expand treatment options, or simply provide the highest level of care to your patients, this is the ultimate resource for understanding and managing cruciate disease. Now's your chance to make a lasting impact for your patients and your practice. Click the link below to get started today. Still on the fence? Let's hear what other veterinary professionals have to say. Dr. Meg Soros, a general practitioner, shares, Cranial Cruciate Disease 101 is an excellent course for any veterinarian wanting the latest research and insights on CCL disease. The course is not only an excellent refresher, but it also presented information that was completely new to me. The presentation is broken into logical sections that are straightforward, easy to understand, and have practical applications for veterinary professionals. As a general practitioner who regularly encounters cruciate disease, this course is a must-have. And Lisa Bedenbaugh, an exceptional PT, certified in canine rehabilitation, said, I found Dr. Romano's course to be very thorough and well-researched. She provides information on many topics relating to pathology, biomechanics, tissue healing, and other issues surrounding cranial cruciate disease. She explains the pros and cons of different types of imaging, strengths and weaknesses of various rehabilitation protocols, and general goals for a successful rehabilitation program. This is a valuable resource for general veterinarians and veterinary rehabilitation professionals looking to enhance their knowledge about a commonly seen issue. From vet students to general practitioners to vets with advanced degrees, everyone can improve their patient care with this knowledge. I want to bring you back to Kaiju's story. 2-year-old border collie with effusion, crepitus, and fibrous tissue at both stifles. Her mom's dream was for Kaiju to compete at the highest level of agility. Early detection allowed us to intervene before a rupture occurred. This is why early diagnosis is so important. Without it, Kaiju's story could have taken a very different turn. Instead of managing a debilitating rupture, we were able to put her on the path to preserving her knees and her future. Fast forward 6 years. Today, Kaiju has no effusion, no crepitus, and she's still competing at the highest levels of agility. She not only competes at nationals every year, but this year she went all the way to the finals at the UKI Open, their nationals. This is what's possible when we take action early and arm ourselves with the right knowledge. Kaiju is a living example of what we can achieve together when we combine skill, science, and care. Did you enjoy this session? Learn something new? Ready to take the next step? Click the link below to sign up for Cranial Cruciate Disease 101, Diagnostics, Management, and Care. Start making a difference for your patients by diagnosing earlier, reducing pain, and slowing the disease progression. And if you're ready to go in, bundle CCL Disease 101 with Mastering Cranial Cruciate Disease in Dogs for even greater savings. By bundling today, you'll save $100 and gain access to both courses packed with actionable insight and cutting-edge research. Remember, Mastering CCL Disease isn't available on our website. It's only accessible now or after completing CCL Disease 101. Don't miss this chance to get both courses and elevate your approach to CCL care. If you have any questions, feel free to reach out to us anytime at dr.laurie@optimumpetvitality.com. I hope you learned something valuable, and I'll see you inside the course.